Respected President, we can start the program now, 7 o'clock.
Good evening, all. Respected State Secretary Dr. Deepu, President-elect of Shibu, our State CD Chairman Dr. Faisal, our esteemed moderator Vagismani sir, our speaker Dr. Joseph Edward, our panelists Dr. Ravindra Nair ji, Dr. Jayanthi P, other office bearers, Dr. Sushant, our treasurer Dr. Fasil, and dear friends. COVID-19 pandemic has been creating a havoc among general population and healthcare system in the world. Post-COVID mucormycosis cases are increasing, and around more than 10 cases today in Calicut itself. Mucormycosis has came as a new challenge for us. General dental practitioner can play a key role in the management of this outbreak of fungal infection and can act as an important referral chain and making an early diagnosis of this disease. With early diagnosis, this disease can manage with minimal morbidity and mortality can be avoided. A COVID survivor has already suffered a lot, affects almost all the systems of human body, and then again, he has to face serious complications with this. Mucormycosis patient might report primarily to a general dental practitioner for an oral cavity related issues. Hence, we are the persons to make an early diagnosis and spread the awareness to prevent the development of mucormycosis. Today, we are really fortunate to have an eminent faculties to discuss about mucormycosis or black fungus. I would like to welcome our moderator, our senior most dentist among states, Vagismani sir, to this webinar. I would like to welcome our faculty speaker, Dr. Joseph Edwards, to this webinar. I also would like to welcome our panelists, Dr. Ravindra Nair and Dr. Jayanthi P. Today, we are acquiring knowledge through these eminent faculties. Let me congratulate the IDCD wing of IDA Kerala State. Thanks and congratulations to our CD chairperson, Dr. Faisal CP. Now we are around more than 1,000 people are attending this program live. Special thanks and congratulations to all who are eagerly waiting to attend this program. With all your permission and blessings, I would like to inaugurate our CD program, The Black Fungus, an Insight for Dental Practitioners. Let us stay safe, stay inspired with these, the most relevant topic. Anyway, we shall overcome this pandemic, COVID-19, someday. Thank you one and all. Jai Hind, Jai IDA. Deepu.
Over to Secretary Dr. Deepu for his remarks.
Good evening, a warm good evening to one and all. President Dr. Joseph, President-elect Dr. Shibu Rajagopal, CD Convener Dr. Faisal CP, Senior most and pioneer of oral surgery in Kerala, Dr. Vagismani sir, Senior faculty of the day, Dr. Joseph Edward and Dr. Ravindra Nair, and Dr. Jayanthi Varan, and all those who are attending today. Welcome to this program. IDA Kerala State, we've been trying to stay on the pulse of the matters and trying to bring you topics of relevance here. And Dr. Faisal has arranged this program today. And at this point of time, the objective of this program would be to reduce the apprehension among the dental community in our state, so as not to panic regarding as to what the way forward with regard to this fungal infection is going to cause. I'm sure that by the end of this session today that we'll be able to get more insight into how the treatment protocols we should follow and what is of essential importance as we see patients in our daily practice and in the days to come. As you all are aware, ours is a profession that has been very well affected by the COVID pandemic. It is difficult times for one and all. And I'm sure that we will, considering the fighting spirit of the human race, we will all persevere and come out together with and see better days and sunnier days. And wish you all a happy learning and stay safe. Thank you.
Thank you, Dr. Deepu. I am interested with introducing the speakers and the panelists for the day. And it's a privilege to introduce our main speaker for this program, Dr. Joseph Edward. Dr. Joseph Edward is currently professor in Department of OMFS in Azizia Dental College, Mayanur, Kollam, and he is also a consultant maxillofacial surgeon in Holy Cross Medical and Benziger Hospital, Kollam. And he is also a visiting consultant in NMC Center, Sharjah, and managing director of New Face Dental Care, Kollam. He is the president-elect of AOMSI Kerala chapter and also an active member of IDA. He has also got innumerable publications to his credit. Having over 20 years of expertise in the field of oral and maxillofacial surgery, he is proficient in implantology, traumatology, and orthognathic surgeries. Today, we have two panelists. One is Dr. Ravindra Nair. Dr. Ravindra Nair passed out from Calicut Dental College in the year 1990, and he was in the government service since then. And he's presently working in Government Medical College, Manjeri. Dr. Ravindra Nair is an active member of IDA. He was the past state treasurer, charter president of IDA Alappuzha, past president of IDA Malabar, and was executive member for more than 11 years. He was also a past secretary and president of AOMSI, and he's also a national executive member twice. Another member in our panel is Dr. Jayanthi. She is a practicing oral surgeon and oral pathologist by profession. Dr. Jayanthi is currently working as a professor in Department of Oral Maxillofacial Pathology in Azizia Dental College, Kollam. She is passionate about teaching and research and has numerous publications in reputed journals. She is the assistant editor of Journal of Indian Dental Association. Coming to our moderator of the day is Dr. Vagismani. He is the senior most and the renowned oral surgeon of India. As a familiar face and voice in the dental academic circle, he needs no formal introduction. But as a formality for the occasion, it is my privilege to introduce him. Professor Vagismani was the former president of Association of Maxillofacial Surgeons of India and the Indian Society of Facial and Maxillofacial Surgery. He has trained scores of maxillofacial, ENT, and plastic surgeons in the field of orthodontic surgery through his famed workshop called FACE, which has been conducting since 1994. He has authored several textbooks, including Orthodontic Surgery, Aesthetics and Face, and Surgical Correction of Facial Deformities. He also worked as Dean, Mar Basilius Dental College, Kodamangalam, former principal of Mar Basilius Dental College, Kodamangalam. He was also a professor in Government Dental College, Calicut. He was president and editor, Association of OMFS of India, president, Indian Society of Plastic Surgery and Reconstructive Surgery, and founder chairman of Indian Board of Oral and Maxillofacial Surgery. It will be a pleasure to listen and learn from all of you. I invite Dr. Vagismani to moderate this program. Over to you, sir. So,
Please unmute, sir.
Okay, can you hear me?
Yeah.
Right now? Thank you, everybody. Thank you, Faisal, for that sweet introduction, for that matter. And let me take a little anticipatory veil, as I told you earlier. I'm not an expert in mucormycosis or black fungus. I tell you frankly that I have not seen even a single case yet. I might have seen a lot of rhinosporidiosis, candidiasis, etc. So we know something about the infections, the fungal infections. To tell you about the mucormycosis, this is something which has come to our place, our country, recently with the COVID-19. So that is one of the reasons why COVID in the second wave is taking the lives of many people, and it is actually surging up. So, and along with that, the mucormycosis is increasing in number. Mucormycosis, as you all know, is a very serious fungal infection caused by mucormycetes. The black fungus is actually a misnomer because it is not having any melanin actually in it. It is a crust which is crust formed after the infection of the mucormycetes that is black in color. That is one of the reasons why it is called a black fungus. From the photographs, I understand that when you look at it, probably you may even mistake it for melanoma, one of the worst cancers that can occur. And another important factor which I wanted to say is that the spores of the fungus is almost everywhere from soil to the environment. This is an opportunistic fungus. Opportunistic fungus is something which means that when your your resistance then goes down, many of the favorable, even helpful bacteria and fungus, which is already in our oral cavity or in the surroundings in the environment, can cause an inflammation or an infection. Though we breathe the spores almost every day, nothing happens for a healthy person. If we are unhealthy and immunocompromised, the chances are high to get the infection. One of the most important comorbidity that can affect, especially the COVID-19 patients, or already existing, is the diabetes. Diabetes is probably most deleterious comorbidity, which can sometimes give rise to the infection by mucormycetes. Uncontrolled diabetes and the patients on steroids. And we know what the diabetes does. Diabetes is actually dysfunction, basically the neutrophils and the monocytes. So naturally, they may not be able to. Phagocytosis will be inhibited. And then when there is a cytokine storm, that is basically the immune system, that is how it works. That is what I wanted to say. And when you are taking steroids, again, not only the diabetes itself is going to reduce the immunal capacity of ours, and it is going to suppress. And at the same time, when you are taking steroids, it is further suppressed. So when this is being, and another important factor is that when you are taking steroids, in a healthy person itself, the hyperglycemia usually occurs. And ketoacidosis is another important factor, important thing that always creates a problem. And well, what is the importance of the maxillofacial surgeons and the dental surgeons in this? This is basically the field. No, the basic treatment has to be probably, it is a teamwork. And we happen to be one in the team. Most of the cases of mucormycosis, the complaints are the swelling on the face, numbness of the area, headache, maxilla infections, abscess, and loosening of the teeth. All these important problems are usually being associated with, naturally the patient will be coming to us first. And we look into it. Definitely, we have to take the history. That is one of the most important things. Whether the patient is COVID affected, whether cured of the COVID, and whether the patient is diabetic, whether the patient was on steroids or any other immunosuppressants. These are certain things that we have to take into consideration before going into this. Usually what happens is that when a patient comes with a pain and a loosening tooth, we doubt it for some periodontitis, all these things. So in such cases, especially in these conditions, when the patient gives a history, you have to go for CT, 3-dimensional CT, CBCT, MRI, etc., and the examination of the lungs as well. Another important area which is being affected is the lungs. And of course, mucormycosis can affect the gastrointestinal tract as well as your skin. So it can affect anywhere in the body. And sometimes it can go into the bloodstream. That is also, you can get it. So what I'm saying is that the importance of the maxillofacial, our role is basically the maxillofacial surgeon, especially the treatment, main treatment, surgical treatment, excision, curettage, and debridement. Because when a dead tissue is there, naturally the blood will not reach there. So that all those things has to be completely cleared. All the necrosis has to be cleared. And then only the amphotericin and all those things, and I think that Joseph will be going to in detail on our treatment plan and all those things. Yes, I think that is all what I have to say right now. And because an extensive talk and I'm sure that erudite talk by Joseph is going to give us a deep insight into the COVID and its aftermath. And of course, Mucomycosis. Thank you very much.
Thank you, sir, for that wonderful introduction regarding COVID. Shall I take over now to the President Secretary?
Yes.
Please go ahead.
Yes. Yes.
Is it audible?
Yes, audible.
A warm good evening to one and all, especially Dr. Vagismani. Respected Dr. Vagismani, the moderator, for sure, senior surgeon, the faculties, panelists, Dr. Ravi, Dr. Jayanthi, respected President, Dr. Joseph CC, Dr. Secretary, Dr. Deepu, the CD Chairman, Dr. Faisal, and executive committee members, as well as our fellow members who are present here for this particular. Must know more in detail about what our need of the hour is in our specialty. To start with mucomycosis, there was a recent WhatsApp image or a photographs which has been coming over in the recent time. So of this, we happen to notice that everybody just had a pass through, but I don't know what the author has really mentioned here, that it is always has a line that mucomycosis is going to destroy India in a couple of years. How exactly it is going to happen means we have started witnessing the same in this with this pandemic. An endemic has come over. What is mucomycosis? It's a saprophytic fungus belonging to the gene. The class of Lysosomal order Mucorales, family Mucrae, and the fungus is Mucil. Before we start with it, I have had an opportunity to see a case which was addressed to me during the first wave of COVID. That is somewhere around 6 to 7 months back. And
Joseph,
yes,
your slides are not visible.
1 minute, sir. Is it visible now, sir?
Yeah, that's fine. That's fine.
Okay. So this is what I was discussing. Somebody has quoted this, and this has been circulated as I discussed. I don't know how they got it, but This is a fact now. The fact is becoming into a reality. Now, my encounter, it was somewhere around 7 months back during the first wave of COVID. During the first wave of COVID, I happened to have a chance to see a patient who was reported. And this particular patient, like 40-year-old male, was actually a native of Nagarkoil, where let me just reuse. Let me just take off this screen, the viewing part of the screen. Sorry for that, Taylor. Give me a minute to just, because otherwise the photographs on has been appearing on my screen, which I'm not able to take it out.
പറയൂ. മീറ്റിംഗ് 2-3 മണിക്കൂറുണ്ടാവും. ഇപ്പോൾ ഇതാണ് ക്ലാസ്സാണ്.
So this patient has actually was a native of Nagarkoil and was married to a native of Kolam. So he came to me with a chief complaint of pain in relation to the upper left region since 5 months. On a medical history, it was found that he was a survivor of COVID-19, which was turned positive on 1st of September 2020. He was a known diabetic for more than 10 years and was on hypoglycemics. Presented his going back to a bit of his COVID journey. He had reported with fever and cough 2 months back before reported to us, and his RT-PCR was found positive. Chest X-ray revealed bilateral ground glass opacities, where his WBCs, which were severely raised up, C-reactive proteins were raised, and his D-dimer, the fibrin degradation result means the D-dimer is the one which you do it for a COVID patients in order to that bleeding part of it, and it's grossly elevated in case of COVID patients. His RBC spiked to a level of somewhere around 518 during that particular time. During this time, he was admitted. He was supported with IV fluids and all the medications, as mentioned, antibiotics, antivirals, and all these things. And he was on oral hypoglycemic agents, plus he was also on steroids. One of the important thing that was, he was supported with steroids and vitamin and nutrient supplement. After prompt recovery, and once his RT-PCR became negative, he was discharged after 3 days after he became negative. Going back home 5 days later, he developed toothache on the upper left posterior region, where with white discoloration in oral mucosa, and also he had some hemoptysis, or we had noticed some blood on his saliva. There was also a mild numbness over the left side of his face. The blood in sputum also appeared to be dark clay colored, and he had been again back to the hospital, admitted in the MICU with bilateral pneumonia, with again D-dimer almost in a control level, but CRP was raised. He had severe diabetic ketoacidosis during that time, and also he says that he had a bit of some palatal abscess also. And oral candidiasis gives a history of white candida or whitish things, or it was diagnosed as oral candidiasis at the time of hospitalization. He again underwent all the same means oral hypoglycemic agents, antifungal, itraconazole was supplement during that particular time, antivirals, nutrition supplements, and all this. And then his diabetic ketoacidosis was managed with IV fluids and insulin infusions. Cross consultations were given during that particular time in his hospital, where ENT had a consultation. ENT revealed that he had chronic pansinusitis, where the sinus of all the 4 sinuses were involved. He did the ENT over there has done a fungal and endoscopic surgery, and he rolled it out as final side because he did a biopsy also along with it, and it reported as fungal sinusitis. He didn't get an exact picture of what organism it was. There were no reports stating that which organism it was. Yeah, he did the first functional endoscopic sinus surgery, and later he was, after hospitalization of 20 days, he was discharged. From the day of discharge itself, or during the time of admission itself, he had pain in relation to that particular side of the face as well as the upper jaw. During a first visit to our hospitalization, when he came over, that is towards the end of September, somewhere around 1 month and 20 days after COVID, after he became COVID positive, he complained of radiating pain from the alveolus, anterior alveolar region towards the head and the neck region. On an extraoral examination, we couldn't find anything related to any skin discoloration or any other than that infraorbital numbness. There was no diplopia or any signs of orbital ophthalmoplegia or anything as such. No, there's no discoloration on the malar, infraorbital or the lower eyelid or on the lateral side of the nose or anything as such. There was cervical lymphadenopathy on the left side and with the mild paresthesia on the left infraorbital region. Intraoral examination, to my notice, I found certain peculiar findings as soon as I reflected elevated the buccal part of the upper left side. I found that there were numerous non-draining fistulas or abscess-like and especially it was towards the canine premolar region and the anterior central incisors region. This is something striking me. And onto the examination of the hard palate, I also found a small white ulcerative lesion posterior to the hard palate. Tenderness in relation to the hemimaxilla was present on that particular side, as well as all the teeth from the left upper central incisor to the molars were tender on palpation. There was grade 1 mobility in relation to the central incisors, grade 2 to the lateral canine, and grade 3 mobility to the premolars and molar region. It was something like hanging, and it was, even though by this time we had something literatures during that first wave of COVID, literature started coming in, stating that there is post-op complications related to mucomycosis in post-COVID patients, and a lot of articles kept on, photographs kept on coming in during this particular time. This scenario in mind in that period itself, and with the clinical features of what was noted, it struck off that why couldn't it be this particular lesion with all these histories related to. So started having this concept in mind and planning what next. Immediately thought of taking a CT or a CBCT in order to rule out what exactly the underlying structure or the underlying scenario is. CBCT, just come up in detail with the CBCT. You can see the report was given by one of the oral radiologist from Chennai. She herself was shocked and called me up as soon as she saw this photograph, saying, or the pictures in the CBCT with gross destruction of bone, like moth-eaten appearance, there is minimal amount of bone in relation to the zygomatic and the maxillary region. It showed that it was not crossing from the left to the right side. It was limiting to the left side alone. And it's involving zygoma, maxillary sinus, nasal cavity, and the bone destruction obliterated the medial wall of the maxillary sinus and the lateral wall of nasal cavity also. The palatal bone in relation to premolars and molars showed destruction. And there was total bony discontinuity into the palatal region. But there is no communication as such. The pathology, this was the finding on the coronal sections and on the axial sections and the sagittal sections. So you can see the amount of bone destruction, and that too, by now there are a lot of cases reported, and during those times only a minimum number of cases started coming in, and to my surprise I was finding this something strange what is going to happen. For if this is going to be the future in all COVID or in most of the COVID patients or something great, that is going to be a disaster to humanity. The report, again, they diagnosed it. One cannot be completely on the CBCT alone, because CBCT doesn't give it forms a diagnostic measure. It doesn't have a concluding element in the sense to confirm your diagnosis. Your diagnosis confirmation is based on your histopathology or SMS or whatever it is. But it can give you an idea, or it can tell you how much of bone destruction, and it can be a measure for you to assess your scale as well as your get a differential diagnosis of what it could be. That's all. Immediately seeing this CBCT and with the amount of bone destruction, I knew that by putting into a needle through the labial sulcus itself, I would be able to enter inside the sinus, because sinus could be separated at this particular point of time. So using a wide bore needle, I went in, I took in an FNAC, 2 or 3 eyes, I took it in order to get a proper confirmation regarding strain. I sent this particular FNAC for KOH stain, as well as one I sent it for a culture and sensitivity. The problem what happens with the culture and sensitivity is that you don't get an immediate result with culture. It takes time for you to get especially for a fungal culture, it takes more number of days for you get your results. By the time the disease will progress more. So a staining, which I think the panelist, Dr. Jayanthi, could explain much more properly, the PAS staining or the potassium hydroxide staining and all these things could be done in order to get a diagnosis. But nowadays we'll come to that, because even if you are not getting a proper diagnosis, the recommended protocol behind this is to start with an early management, because you know exactly related to the findings of what is happening. It is a mucomycosis and treatment has to be aggressively started. So along considering this in mind, having this in mind with the report, then it was my task to inform or counsel the patient regarding what is going to happen, because after mucomycosis has got a mortality rate of somewhere around 54%. And then the morbidity, what is going to be creating, or the disability part of it is, once you're going to start with it, you don't know where it is going to end in and what is going to really happen. That has to be properly borne. Having the patient and the bystanders with me, I clearly explained to them and had a multidisciplinary communication with all my departments there, especially with the physician as well as the ENT surgeon. Dr. Kanagarajan was the leading ENT surgeon over there. And with them, they had insisted me to have a detailed counseling. And then with the counseling, I told them regarding the seriousness or the intensity of this particular disease. Anyhow, we had no other choice was there other than to address the patient at that particular point of time, because we can't leave it as such. So the treatment was nothing other than a surgical debridement to start with antifungal therapy and all this thing. Now let me stop with this particular, and then we will come back with the patient scenario. By the time, we'll just discuss a bit on the details or the regarding mucomycosis, a bit of its clinical aspect, the clinical finding. Then we will conclude, or by the end of the session, we will be able to go with the case of how we have managed to. An insight into mucomycosis. As I told you, it's a saprophytic fungus. Mucus is a fungus across 50 species, and mold could reside in, as Dr. Vagismani told, it can reside anywhere, in plants, in decayed foods, or in rotten things, whatever. It even lodges in a mucous membrane of the sinus, the lining of a nasal cavity, where it is lodge. But it is there everywhere. But in a healthy adult, it doesn't do any destruction as such. But the time this is being overridden when the immunity status of the patient is taken over, or when the patient is severely immunocompromised. When the patient is highly diabetic or is not under diabetic control, or glycemic status is not under control, then this opportunistic infection takes over, and then the seriousness of the infection really starts on. In COVID patients, SARS-CoV, this has becoming a life-threatening thing now, and that is because of the depletion of CD4 and CD8 is leading to the immunocompromised state of the patient. This rare opportunistic fungal infection characterized by infarction and necrosis of the host tissue that result in invasion of the vasculature by hyphae. What happens here is this invade the vasculature or the vessel, cause a thrombus formation over there, blocks the supply to that particular area, causes necrosis of that particular bone and soft tissue into that area. So, and that too, in a normal patient, this is what is going to happen. And especially when you have an immunocompromised patient, or when you have a diabetic patient, he is already compromised with so many things, so that this becomes an easy pathway for the spread of infection. It has got a tendency to spread overnight from eyes to the cranium. That is, then it is mainly classified into 4 types. One is your rhino-orbital, pulmonary, gastrointestinal, and miliary type. The one which we commonly find is the rhino-orbital, and this is mainly with mucomycosis. A pulmonary one is one which is actually, it is not more of mucomycosis, it is aspergillus. And then gastrointestinal and miliary are something which you have aspergillus or, but what we commonly encounter is a mucomycosis which is been associated with our sinus, our nose, and our orbit and our cranium. So once we have the scenario, once a patient comes to us, there's no doubt with all these peculiar findings, easily we can come to a conclusion, because sometimes if you whatever smear you do, sometimes you might not get a correct picture, or it might show a false report regarding the same. It might not be a confirmatory, but still then you shouldn't rule out saying that your result regarding the histopathology or the smear or the biopsy report or the culture growth didn't show that, and so it is not going to be. It is because at this point of time, this is the one which is attacking our nasal cavity, our sinus, as well as the orbital cavity and the cranium. A bit of the pathophysiology of what happens here, as I told you, when this force from the environment can enter into your skin or your mucous membrane, and the factors that impair the host defense mechanism when there is a alteration in the host defense mechanism, or when there's a breach in that skin or mucous membrane, it enters your, from the antrum or the nasal mucosa, it enters into your vessel, your blood vessels, and this special ion accumulation mechanism occurs where cell wall composition and genetic alteration occurs here. Rapid growth of this fungus evade the host defense and expression of this COT-H protein on the spores of the hyphae. These are some of the proteins which bound to the receptors of the cell wall, and what here happens is they attack the cell membrane and cause depletion of it, and then factors addition to the receptors of the endothelial cell, angio-invasion and dissemination occurs. It spreads, causing angio-invasion resulting in hemorrhage, infarction, and suppurative inflammation in various organs. Thereby, it forms a thrombus over there, blocks the and decreased blood supply to that particular area, causing necrosis of this particular area. And that is how you end up with losing of your tissue all around. The similar manner, it's pathology, pathophysiology with the hypoglycemic patients. Hypoglycemia, glycosylation of protein from transferrin ferritin, this decreased ion affinity and accumulation of ketone bodies occur here, thereby lowering the pH of the blood, impairs the ability of transferrin to chelate ions, leading to increased free radicals of ion and glucose and ketone bodies, and then thereby this becomes a house or host for the bacteria to grow, means for the fungus to grow on it. Either this, as told, mucomycosis was not a new disease. It has been evolved during 1885 was the first the year which it was discovered, and somewhere Dr. Paul has recognized this thing, and then it was in a century or more back. But still then, during the SARS-CoV 2003, and in the olden days, the percentage of this was somewhere around 0.005 to 1.27 in 1 million was the cases reported. But after the SARS-CoV-1 in 2003, there was a gross increase in the number of cases, which has risen up to somewhere around 20 or more. During this pandemic in 2020, after the with the COVID-19, this has come back, and it's rapidly spreading. It can occur during the COVID phase or post-COVID in post-COVID patients. The interesting fact now is that one doesn't need to be a diabetic. Even it has occurred, it is occurring in patients who are not known to be diabetic, as well as they are known to be diabetic. One of the reasons that could be is most of the patients who are post-COVID patients who were not diabetic are having raised blood sugar level after COVID, and COVID has proved that it can increase the glycemic status of the patient right now. So that could be one of the reasons. And the people who doesn't have a history of COVID, we exactly don't know whether these people or these patients who didn't have a history of COVID or not, because there are so many patients who didn't, or so many of us, or even we ourselves doesn't know, even though we were not having any signs or symptoms, have we gone through a phase of COVID, or were we asymptomatic during that particular time, since we didn't have any symptoms or such. So that could be one of the reasons, or there are something yet to be found out whether why this is occurring in healthy patients without the history of COVID, or who are not diabetic also right now. Because recently I read through an article regarding the same, that youngsters who are not diabetic, who didn't have a history of COVID, are also getting mucomycosis. But there's no literature out there. This comes as a as any media news or something related to like what you get it. And that is from sources which are operating them. and it's exactly sources where cases are in large number. Why is there a sudden mucus surge now? As we told, you just discussed about it right now. COVID-19 tendency to cause as well as worsen diabetes mellitus, or a patient who is not diabetic, not a known diabetic who has gone through a phase of COVID, can have a raised blood sugar, can become diabetic. Immunocompromised patients who are on immune modulators, as well as organ transplant, who have done organ transplants and on immunosuppressant drugs as such, steroids, as well as medication like tocilizumab, worsen the immune status of the patient. So drugs like immune modulators have a major role in bringing down the immune status of the patient also here. And the severity depends upon the immunity of the patient to fight against this, the general health status, the blood sugar level, the immunosuppressive treatments what the patient is undergoing. From our point of view, what is important as a dentist? Now we need to, and our role comes over here. As I discussed, or during the start of the presentation, what I discussed to you regarding our case, we need to stress or look into certain criteria, certain points regarding. For this, what we usually do when we do a case history, we take the systemic evaluation as such as diabetes, hypertension, cardiac problems related, renal problems, or liver problems as such. But now our case history should stand apart, leaving apart as COVID or COVID related problems, whether the patient was COVID positive. If so, how long was he hospitalized? Was he on an ICU? Was he on a ventilator? Was he on oxygen therapy? Had he been supported with, had he had pneumonia or something? Was he supplemented with some steroids? All these criteria has to be noted down exactly. And in order to get a clear-cut diagnosis or a clear-cut conclusion regarding when a patient comes to you, either if the patient has got any symptoms or not. Because the interesting part of it is when a patient comes to you, he might tell you that he has got a pain in relation to that particular area, or the side of the face, or the jaw, or his eyes, or whatever it is. The thing is, if you're going suddenly for a CT or a radiographs to a certain extent, that's limited role. But in your CT, if the patient is on an initial stage of mucomycosis, nothing would be ruled out because already fungus has invaded into the mucosa. It crosses the mucosa, it enters into the bone or the bone marrow. And during this particular time, there might not be much of evident reactions or anything which is noticeable in a CT, or the findings would not be confirmatory for you to tell you. So at this particular point, you need to go back with a case history, a detailed case history regarding the scenario of the COVID journey of what he had faced, or if he hasn't anything related to his diabetic status, his immunocompromise, was he on steroids, and all these things as such, which will just come in detail as we progress on. The predisposing factors, the signs and symptoms, the clinical examination, the radiographic diagnosis, and the histopathological counterpart of it. The major risk, I think there is a bit of repetition in this because this is the point where we have to look into, and so we need to stress on these particular areas. The major risk factors which contribute to are steroids tend to decrease the, means even though steroids are a potent life-saving drugs, it has got its own side effects. So during the time of COVID, especially in case of pneumonia, one has to be supplemented with steroids, but the disasters are the post effects of this particular drug would be with ending up with a increasing the hypoglycemic status of the patient. But they at the same time reduce the immunity, boost up the blood sugar, and both diabetic and non-diabetic patients. Either a non-diabetic patient can become diabetic, as we all know, when we treat patients or when the patient is on a steroids who comes to you with either with some sort of immunological disorders or an organ transplant and all these things, because we routinely see all these patients in our clinic. This immunocompromised state can lead to the lodgement of our mucomycosis or spread of mucomycosis. Immune modulators, as I told you, comorbidities like cancers, post-organ transplants, prolonged ICU stays, mechanical ventilation, oxygen, long-standing oxygen therapy. There's no supportive evidence or literature which says that pure oxygen will support the growth of. Actually, it doesn't. Fungi doesn't grow on pure means on oxygen as means on pure oxygen as such. The fact or the study states that. So it is a point of controversy because there was a discussion in the morning regarding this in a maxillofacial. There was a lecture and which says that I got this information from that by listening to that lecture regarding that oxygen is not a substrate or is not a factor which induces or promotes fungi to grow in over there. Never, this humidifier bottles can cause the growth or increase the growth of the fungus. There are a lot of misconceptions coming in, and that is without literature evidence. So now we have a major role here. If we notice that there are some misconceptions or with no evidence-based literatures coming in in the WhatsApp group or in a Facebook, please do not promote it because it's not an evidence-based or it doesn't have a scientific value or it is not a scientifically proven thing. We ourselves is harming the community by passing this wrong information as such. So as a professionals and knowing the facts behind it, we should never ever do in order to promote or without a scientific basis or evidences, we should never even pass on these informations to anybody. Just forget it and leave it up, because once what we are going to what is an evidence-based thing is the one which we have to look into, or we have to keep on communicating to the public as well as to our colleagues as such. And to add on to the discussion, it was found that the people who had operated the maximum number of cases, I think somewhere a doctor of our fraternity, maxillofacial surgeon, Dr. Nihal Patel from Gujarat, he has operated somewhere around 35 cases during the first phase of COVID with mucomycosis. And according to his experience, what he had told us is, when there is an involvement of the sinus, what usually happens is, if the fungus spreads to the sinus and it takes up a path towards the lower tract that is involving the sinus, lower to the alveolar region, it's a bit, the aggressivity, even though it is aggressive, it is not that aggressive as what it takes up to the post of reaching the orbit and all this. But if the lesion starts somewhere in the orbit, or the patient comes to you with the clinical signs which you're going to discuss, then it is going to be much more aggressive than what we, and then the spread is going to be more towards your cranial base and all these things, which is going to increase the mortality and the morbidity, or even the morbidity rate of the patient or the disability of the patient. So things has to be addressed properly. The explanation given for is the sinus is low, as well as you have the lodgement over there. Means that I'll be adding on to that regarding the dental counterpart of it towards when I come across the clinical findings or the clinical evaluation of the patient as such. This is one of the good flowchart given in the Lancet of infections published on the year 2019. And this is done by a global article published in the Lancet with taking into authors from different SAARC countries as such. And even India has contributed to. And so they have given a definitive guideline and criteria regarding the different types of COVID, mucomycosis infection that could affect and what type of infections they are and how it is. You can take a screenshot of it and just go through it because it gives a detailed idea regarding the spread of it, as well as the sampling, the histopathological aspect, and the serology test what you exactly for a fungal infection, what has to be done. This is what I was talking to you. Mucomycosis, the spread, it can be from via antral, via rhinoorbital, and cranial. As I told you, the aggressivity is much more in case of more than that of an antral, because you get a bit of time to address if it is more antral. But
Hello, Dr. Joseph.
Connectivity പോയി.
Just wait, I'll talk. Dr. Joseph will be back soon. Dr. Josephine connection പോയിരിക്കുന്നതാണ്. Wait.
Am I audible now?
Yeah.
Screen has been shared, right?
Yeah, screen share. Okay, fine.
Okay, sorry for that. Yeah. So I think we just stopped with the gravity or the spread of it, right? On the antral region, or if it is involving the sinus, means the sinus, we often encounter with slow spreading towards the lower alveolus as such. Then means, and once you are able to remove those part of it, the further progression of the disease to the upper part or your orbit or your nose as well as to your cranium can further be prevented or just taken care of or controlled with us. Now, the signs and symptoms as we were discussing with the part of the dentist or our dental surgeons are mainly here, means encountered here. Our role, we have got a terrible role over here as dentists because more than the physicians or the ENT might get a case with a blocked nose, or the ophthalmologist who forms a part of the team might get a patient with an ophthalmoplegia, ptosis, or a proptosis or something related to. But more than that, when a patient can come to you with a lot of symptoms related to which we'll discuss one by one. So we are the ones who might address with a lot of patients with mucomycosis in future, and there's nothing. If we follow certain protocols or standards regarding the clinical history, the evaluation, the clinical signs, and all these things, we might be able to save the patient's life, or at least to reduce the and save the life as well as reduce the morbidity or the disability of the patient to a certain extent. Because a person who is left alone, undiagnosed, or due to the aggressive nature of this particular disease, it can extend or it can take up a path where it can end up with severe morbidity leading to your loss of vision, your orbital acceleration, and plus your ultimate or fatality of the patient as such. Here, that is why we just discussed about the detailed case history and the meticulous clinical evaluation or the examinations of patient. As I told you, the extraoral examination plays a major role here. We'll have to look into when the patient comes to you, is there any puffiness of the face, edema over the infraorbital regions? Is there a discoloration on the lower eyelid, discoloration on the lateral aspect of the nose, numbness on the infraorbital region? Is there a numbness or paresthesia? Is there a restrictions in the eye movements? Is there a visual loss? Restriction in ocular movements as such? Proptosis, ptosis, proptosis, as protruding of your eye out, ptosis, drooping of your upper eyelid. Is there a double vision, diplopia? All these things have to be taken care of or to be addressed when the patient comes to you with, specifically when he or she complains of a mild headache, fever, acute sinusitis, and with nasal congestions not responding to drugs as such, your discharges from the nose, brownish or bloodish tinged discharge, pain, headache, and these type of pains are so severe that it doesn't subside with your painkillers. Because recently, 1 week back, I had an opportunity to see one more case, a case which has not been proven yet, but still had a call from ICU with a patient complaining of severe pain to one side of the face and on the upper jaw. On an clinical examination, I couldn't find anything relevant related to a dental problem as such. There was no cavity, no root stems or anything related to which could cause so much of a pain. TMJ was normal, but he was a COVID positive patient, became COVID negative and was having pneumonia with oxygen supporter. He was in the medical ICU. Looking into his oral examination, I couldn't find anything as such, but there was severe or terrible pain, which was not at all subsiding with any potent painkillers as such. Ultimately, with the intensivist also had the same idea in mind, whether it could be going for a mucomycosis. We had, with the help of this ND, consulted the ND and discussed for a CT. CT showed an inflammatory as well as mucosal changes or mucosal thickening in the sinus, where the patient was taken over by the ENT to do a test and for a biopsy. And we are on the verge of looking into what is really going to happen. It's about 3 to 4 days back. So in a similar manner, as I told you, in the initial phase or in the initial phase of mucomycosis, there won't be much of a clinical or means related signs and symptoms, nor a radiological finding, which is so much evident in a CT to rule out or say as such. Here, the part is mainly divided into 3, because when it comes with the involvement of a upper jaw, actually it usually comes with a dental or a maxillofacial surgeon. When it is involving a sinus without any other symptoms related, the ENT takes over. And if it is an orbital involvement with the ophthalmologist. So never it goes as a single person or a single man decision. It is a multidisciplinary approach in order to which we will discuss, because once we start or once we diagnose or once we have a patient with mucomycosis, you can't go with or deal with it alone. It is a multidisciplinary approach consisting of a neurosurgeon, ophthalmology surgeon, an ENT, a maxillofacial, dental, intensivist or a physician, and you have your microbiologist and team coming in. So it is always a team approach in order to address this particular patient, in order to get a proper diagnosis and go with the treatment plan as what we plan for. Coming to the loss of, means the other findings are loss of sensation over the face, that is you mainly why it affects the infraorbital region is just because the infraorbit is on the roof, on the floor of the orbit as such. So an inflammation inside the sinus can also affect it. And at the same time, there are a lot of debates regarding a perineural spread and all these things. The perineural spread is nothing but you have an associated neurovascular bundle with it. That is, nerve is never alone. It has got an artery and a vein together. When there is a blockage or a obstruction with the vessel as such, it causes a necrosis of that particular nerve as well as the artery over there, and that is how it can lead to, or the inflammation related to that particular nerve can lead to your loss of sensation over the particular part of the face. Puffiness of the face, discoloration in any part related, either your lower eyelid, your lateral aspect of your nose, your edema over the side of the face, redness, swelling, and on an intraoral examination, as we have discussed for our case, you get non-draining fistulas or abscess related. Then you have your teeth, which have loosening of your teeth. And especially the canine and in the initial stages when the patient comes to you. This is a point to be noted, because the canines and the premolars are the ones which are initially attacked. And that is because of the anatomy of the sinus as such. The maximum depth of the sinus or the anatomy of the sinus, the floor of the sinus is much lower towards the canine fossa, the canine region. and there is easy spread of infection towards the roots of that particular tooth, where there's easy invasion to the alveolus over there, and that is how the premolar or the canine becomes loose. So an advice to my dear colleagues is that if a patient comes to you without any history of any related periodontal problems as such, or a periodontal problem related without, means not constraining to canine or a premolar region alone initially with mobility, other grade 1 mobility or whatever it is, make sure that there's no other related findings right now. You have to have something in mind that whether is it a mucomycosis, and that can be ruled out because there were a lot of controversies regarding whether an extraction can be done or not. If what can be done is, you better don't go for an extraction, because if by any problem it is a mucomycosis, what is going to happen is you might not be able to address the problem then and there. But if you have a reference to a maxillofacial surgeon or somewhere, the ideal choice for the maxillofacial surgeon would be to go in for an extraction of that particular teeth, so that in order to find out whether there is fresh bleeding from the socket of the tooth, because we can always convince the patient, motivate the patient, counsel the patient, and say that he or she might refrain from taking and getting an extraction done. But the gravity of things has to be explained to him properly. And then by doing an extraction, you can always find out whether there is bleeding from the socket. And if you find that there is no bleeding, your diagnosis is that the patient has got a mucomycosis which is affecting the palate, means the antrum, the alveolus, as well as the maxillary part. So then the treatment is going to be more of an aggressive type. Your bone itself will be brittle. You have dark, or your tooth itself, the root surface will be dark colored, or you might not encounter any bleeding from the socket of that particular area. So it is always a caution to do an extraction, or either if you can refrain from an extraction in this particular point of time for a post-COVID patient, at least for a period of time. Nowhere in the literature or no studies have been ruled out to refrain from doing for a normal dentist to refrain, and to how long, and there's nothing as such a clear cut or no literature or nowhere to substantiate. But listening into one of the lectures recently been talked today morning by the maxillofacial group, one of the Nehal Patel, one of the senior surgeons who have operated somewhere around 400 cases of mucomycosis during this first and second phase of COVID, has addressed that. He himself has given a thought regarding the effect of the canine and the premolar region getting affected first with the extraction. What could be done in the initial, in order as a diagnostic measure, in order to find out whether that is, because ultimately it might be for the good. If you have a bleeding, of course you're going to lose only tooth there. You can always replace it. But if you are not diagnosed it properly, or if you encounter with a non-vital area over there with sequestrated bone or with necrotic tissue and all these things over there, then that is one of the things which has been diagnosed, and you can go for early management at that particular point. Blisters, coming to the discoloration of the face, you have redness or blackish discolorations, lower eyelids or whatever it is, blisters or ulcers on the face. Mainly your ulcers would be more towards the intraoral aspect, discoloration, ulcers on the palate, all to the nasal region and palatal issues, scabby white tissues on the palatal region as such. This is one of the common findings which you notice in a mucomycosis patient. In this what I was talking was in the initial stages or the early stages of the disease. In a moderately or advanced stages, as I told you, if it is extending right from the antrum towards the upper part or your orbital part as such, it ends up with a rhino-orbital mucomycosis. And when it extends more further, you're going for a cerebral. In the second phase or this moderately advanced stage, you have severe orbital pain, ophthalmoplegia, edema, cellulitis, of your lower eyelid, redness, even blackish discoloration, diplopia, your double vision, ophthalmoplegia, where I told you, ptosis, proptosis, protruding of your eye, and you have either partial or blurred vision, or partial loss of your vision, or your vision is completely getting lost, or you check for your fundus examination and your vision gets altered. For this, you need the help of, you can't manage the situation, you'll have to get the help of your ophthalmic surgeon in order to rule out. And if the associated findings are with the intraoral findings, then of course. Otherwise, if you don't have an intraoral findings, now it is a part of the ophthalmologist or the ophthalmic surgeon to go in and see what it is. And then the treatment then becomes a multidisciplinary thing. The third phase, or when it is severely advanced, you have the second to the fourth, the sixth cranial nerve involvement, and it involves the cavernous sinus, where you end up with severe problems such as disorientation, seizures, strokes, because it is ultimately invading into the vessels or the blood the arteries in the brain, as well as by causing thrombosis and block. Is going to be all the mortality is, the severity of the disease is so high that it has to be aggressively managed or addressed promptly or in an emergency manner, without even waiting for your reports of diagnosis, biopsy or your culture reports. You can easily, and the reason concept is that you have to go in directly address the problem as such, and that too, if needed, to start with the medical management first, and then medical management by the time you prepare everything, and then go to the surgical counterpart of it, and then continue. If it is not to that extent, of course, surgery alone have proved a lot of results without your medication or medical management as such, which we will discuss when we are going with the management part of it. Now, for our fraternity, as dental surgeons, suspect mucomycosis if there is mild fever, headache, unilateral facial pain, which we have discussed all this, but we're just rushing through or getting a bit of a glimpse more. Facial pain, numbness, swelling, sinusitis, epistaxis, or brownish or blackish discoloration or issues of non-draining fistulas or ulcers, visual disturbances such as diplopia, ophthalmoplegia, orbital pain, these things, and tooth pain related to your upper anteriors, right from, as I told you, the premolar, first premolar, second molar, or any of the tooth can be involved, as I told you. As it slowly progresses, or the severity, as the severity, so that even it can spread in an overnight from orbit to the cranium, and that aggressive nature, that is the aggressive nature of this mucomycosis. It can end up with the loss of vision, shortness of breath, chest pain, effusion, worsening of the respiratory symptoms as such. Seizures, when there is a cranial or cerebral involvement, you end up with seizures and stroke. So, keeping all these clinical findings in mind, we should always be, it's our responsibility and our duty to address a patient, to see a patient, to diagnose a patient with a case of mucomycosis which comes to you, or each and every patient has to be taken into account with a proper case history noted down, because ultimately if you are going to lose something, might be you will be in the, means you are doing some injustice to the humanity with this profession. At the same time, in a court of law and litigation point of view, you will be held responsible. So it is not the litigation part. Ultimately, it is the part of professional ethics which we have to look into, where we are bound to and negligence from our part will be one of the most serious offense which can even result in mortality or be fatal for the patient. Coming to the investigation, a list of investigation which what we can do, as I told you, is your complete blood count, your CBC, CRP, your galactine, your D-glucose and blood sugar, D-galactine, which are specific tests which you do for your fungal growth of, and your blood sugar level has to be checked in, and not especially your fasting or random. You have to look into your HbA1c, your glycosylated hemoglobin blood sugar level. Pus from sinuses or abscesses for culture or for KOH mount or fungal culture should be done, or pus staining. Well, endoscopic procedures can be done for collection of pus or biopsies, which with the help of means or the ENT can guide you to do that. Renal function test. Of course, this has a major role because your systemic drugs, what you're going to give, the adverse effect of your systemic drugs, which we'll discuss, is one is nephrotoxicity. So regular renal monitoring has to be done when you supplement this drugs, systemic drugs for your patient with mucomycosis. And of course, the chest X-ray will also give a bit of regarding the particular state of the disease or what if it is involving the chest as such. X-ray has got a limited role over here, because if you're going to start with an intraoral X-ray or something, or when the patient comes to you, you can go in with an IOPA if you have an IOP in your mind to see whether when there's a tooth, mobility of the tooth, and see whether the tooth has got a sound bone or what is the reason for the mobility of the tooth. If it is, you know how a periodontal infection gets up or takes up, because you know what the amount of bone loss or how it is expected to be. Keeping this into consideration, and if you do an IOP itself, and if you feel that this is not similar to what you find in a periodontal disease, you will have a basic idea. But more than that, I think it is always better you start with a plain CT scan, which will give you a clear-cut idea regarding the diagnostic part of your disease, or to the extent of how much the involvement, what it has, or what could it be, or what is the nature of the disease as such. Even though it doesn't give you, CT is not a, or the radiological finding is not a clear-cut diagnosis for any of this thing, but it exactly tells you, we can come to a differential diagnosis of what it could be, at least. MRI, especially with contrast, when there is soft tissue involvement, that is, it's involving the orbit or your cranial base or means cerebral part, then of course MRI will give you a lot, and especially in the orbital cavity, if it is involving the muscle, the perineural, the muscles are getting involved, and there's inflammation of these muscles, you can easily note it down so that you can take prompt action and do necessary measures with debridement or removing the affected part, so that ultimately you can save the vision of the patient as such. And then the reason one of bone scintigraphy, which is not that available for everywhere, at least if it is available, but it gives you an exact or more accurate idea regarding the amount of bone involved, as well as the inflammatory bone over there, how much of the bone is inflamed and affected with this, because a clear-cut guidance for the surgeon, and that should be immediately done just before the time of surgery, so that because day by day, or if you wait for a day or two, because by the time the patient sees you, you have a CT in your hand, and when you're going to address the patient, you will see that this is totally gone. There is more of involvement which could have affected the opposite side, and it's so rationally, or it is so aggressive that even the nature or the image what you have would have totally changed up. There's no reliable serological PCR-based skin test for mucomycosis as of now. how it can be prevented from a dentist point of view. I don't think it can be prevented, but how it can be controlled or how we can do good for our patient is with a proper history taking, clear-cut history with what we have discussed, having separate charts to keep our COVID journey, right from the detail, hospitalization, MICU, oxygen, steroid therapies, and all these things has to be meticulously noted down. And then with meticulous clinical examination, as what we discussed, extraoral findings, the intraoral findings with clear percussion, palpation, visual, and which you come up with the radiological findings of what you get. You have to do it. Now, if a patient comes to you, even without any of these symptoms, our basic protocol should be, in order to address our patients, to keep a good oral hygiene, to have regular oral mouthwashes, to maintain good oral hygiene at that particular point, especially if the patient is diabetic, to check into his diabetic status, maintain his diabetes status under control, have his proper medications, and have a regular follow-up of checkup to note down if he has got any signs and symptoms related to what we have discussed, to report back to any doctor at the urge or in an emergency manner. Prompt management, reference to higher center on the preliminary diagnosis itself. You don't have to wait to get a clear-cut diagnosis regarding the same. If you have a doubt, there's no trouble in referring the patient, because the patient ultimately will be thankful to you, because you would be the first person to diagnose him and to save his life. So at least you could be proud of yourself that you have done something for your humanity as well as doing good for your profession. In suspicion, radiological modalities and histopathological slides, KOH staining, KOH mounts will give immediate results for you, but sometimes it might not also give you, it give you false results which you can't rely on. So don't go according to based on your this thing alone. And then maintaining your blood sugar level within normal limits before any invasive procedures as such if you are planning for. Make sure that if you can, do all these things. During COVID treatment, by attaining good glycemic control, your blood sugar status should always be brought down. HbA1c should be less than 6.5. And if you are using steroids, make sure that it should be used in a proper judicious manner. And I think most of us minimally use steroids in our scenario, except except for some emergency or for some surgical procedure as such, and that too not in a regular manner. Clean, sterile water for humidifiers during oxygen therapy, but again, it's a subject to be discussed because it's again a controversial thing. Guidance for the patients, what can be given for our patients? Ask them to give a clear-cut history of diabetes to the doctor whom they are addressing. The glycemic control should be brought down. Watching for early signs of muco as explained and reported. For that, what you can do is you can even chart it down or put some posters of early signs and symptoms in your clinic. Maintain basic oral, ask them to maintain the basic oral hygiene. Supplement them with high protein and low sugar diet, because I told you in post-COVID patients, even non-diabetic patients are turning out diabetic, and that there are so many explanations given for the same. Regular uses of mouthwashes, betadine, and 0.5% of betadine nasal irrigations can also help a lot. Team inhalation as advised by your pulmonologist or intensivist. Following medical advice, take complete course of treatment as suggested by the doctor. And especially in cases of any other related infection, you'll have to take care of this particular bacterial infection. In cases of root abscess or related any space infections related to abscess, it has to be addressed other than COVID. That also has to be addressed then and there itself. Don'ts. Always ask them not to go for self-medication, especially steroids, or misuse of this antibiotics, which commonly all people do. Delayed reporting symptoms of muco, ignoring medical advices, and that too, especially if the patient is too illiterate or even needy. Literate patients are more prone to all these things. To consult a doctor immediately in time of emergency or at any point of time when they feel that it's an emergency. Dentist protocols can be modified in such a way that regularly, what I think most of us have changed our regular routine practice to a much more modified way of using betadine goggles before you start with an operating procedure. 2%, and even a small spray or irrigation of 0.5% of nasal irrigation can be done. Glycemic status, maintaining good oral hygiene, which I've already discussed. Deferring elective procedures. Again, this is again a debatable thing, because if we can, in post-COVID patients, ultimately without any signs and symptoms of any mobility of any tooth as such also, if it is an elective procedure, something like an orthodontic extraction or something which you can wait on, it is always better that you can postpone your elective extraction or a surgical procedure to a minimum period for the post-COVID patients. But no way in the literature has any evidence-based thing regarding the same. At least what we can discuss on it and make a protocol regarding the same. Display of information with posters regarding mucomicosis, the early signs and symptoms. And one more thing, what I would like to add on is educating the patient to use the mask promptly, in the sense, we know that our mask, what we use, gets contaminated by the 4th hour of it. It is supposed that we are supposed to change our mask in a 4 to 6 hour duration. More than that, so we have to use either 2 masks on a day of morning and evening practice as of now. Or it's been routinely, means that is the protocol, but rarely most of us do it. Of course, we often change it in a day or two, but there are patients who keep on addressing the same mask for 3 or 4 days or even more without washing it. And if it is washed, they might not be changing it. It might be damp and wet. And if they're going to use it back, again, it is not based on mucomycosis alone. This wet mask can form a nidus where it can cause so many infections for the patient. It can easily transmit all this infection to when you're going to take in and inhale and expel out. So that has to be educated promptly. And even from our side, if we can pass on this message to the authorities, it would be good enough from our side to address the patient promptly in order the use of mask and how to wear it, as well as when to change it and how to. As I discussed, dealing with mucomycosis is not a simple procedure as such. It is a multidisciplinary approach, because it cannot be handled by any single or an individual person. As I told you, when it gets involved with the oral cavity, we are the first person to diagnose it. It can be addressed by the oral and maxillofacial surgeon or the plastic surgeon. If it is extending beyond the maxilla, high up into the orbit or rhino-orbital spread, then you automatically need an ENT surgeon over there to support you to do it when you're doing a resection or doing a debridement, in order to help you out with the endoscopic examination or a debridement. You need the help of an ENT, or the ENT has got a major role over there. And at the same time, as it progresses more up, or when there's an orbital involvement, the ophthalmic surgeon role is over there. And it's always a debate. It's not a debate. It's when the spread is so severe that it might need an orbital excineration. We might have to remove the orbit as such. And that too, when there is a vision loss. And if you're going to, either you'll have to salvage the orbit or you'll have to salvage the patient, means you lose the patient, because keeping it over there, and if the spread is too high, it is going too aggressive into the cranial base, then there is going to be a morbidity for the mortality for the patient, which has to be taken care of. So, and that too, if you have to address this particular scenario, the ophthalmic surgeon's important is there, because removing an eyeball is not that it's not that easy, or any surgeon can do it. But from a legal point of view, you need two ophthalmologist opinion and signatures in order to, with regarding proper explanation to the patient regarding the status or the complications that would encounter if it is kept back. Considering these facts, the patient has to be educated, and then only after getting proper consent only from and with the help of two ophthalmologic surgeons, ophthalmologists only, you can go with the orbital excineration. The neurosurgeon here has got a major role if it has gone up to the cranium, because when it's involved the cranial base, and once you're going on debriding the bone over there, what really happens is you will end up with the CSF rhinuria, or if it is crossed over there, then you might, if there is any, you need the help of a neurosurgeon over there. It's not actually not better to have a neurosurgeon at the time of operating, or combined with a neurologist if it is not that extensive. An intensivist, as we discussed, is needed at the hour over here, because renal toxic drugs are being used over here. Renal measures or renal status has to be checked regularly over here, and that has to be taken into account. And then, of course, your microbiologist, and our role has already been explained, and a biochemist who dispense your medications now are the team which comes. And these are the guidelines being put forward by the ICMR, as well as it's come out from the AIMS has put forward. This approach means the standardized the team, as well as they have put in certain guidelines regarding the early findings. What I have put it down, the early, the moderate, or the late find, means the aggressive or the late findings. What you have found is all these are being put in by the All India Institute of Medical Science, and this is by the ICMR. Now coming to the management part of it, you have medical, surgical, and supportive therapy. As I told you, the medical management, there is no time to waste over here. Once you're diagnosed with, and once you see that it is an aggressive type, if it is involving the maxilla alone with the alveolus or the mobility of the teeth as such is involved, and there is not much of an involvement towards the orbital region or towards the basal skull as such. Now you have a bit of time to do your basic investigation in order to post the case for the procedure and go for an emergency procedure as such. In certain situations, surgical planning or surgery alone might be sufficient enough to completely take care of the problem as such here. But if it is going for an advanced stage, or it depends upon the severity of the disease, where the supportive measures or the medical measures has to be taken into account immediately in order to suppress or bring down the infection, or to at least take care of the infection. And then by the time you plan up for the surgery, or you have a limited time in order to address certain problems as such, and then you go in with your emergency management of surgical plus counterpart your medical management as such. Coming to the medicines which are being used, it is nothing other than amphotericin B, the drug of choice and the only drug which is being given for mucomycosis. Posaconazole does do good, but not completely for mucomycosis patient. It does more good for aspergillus and all these things. But since these are, and it doesn't need, means the recent studies or the latest literature says that it doesn't need to be combined because both of them act in the same manner as they are bound to the vitamin D and their action is just the same. So both these drugs doesn't need to be supplemented together at the same time. And these are salvaging drugs because due to the scarcity of the drug in our country right now and the crisis what we face now, if we don't get a particular drug, we are opted to have a second drug, at least to cover up to a certain extent of what we have to. And so certain other drugs like posaconazole, isoconazole, and all these things are being used, but not as good as what amphotericin is. So amphotericin is the drug and the drug of choice alone for your mucomycosis. Effective blood glucose management, control of the underlying condition with appropriate medications. Your systemic conditions has to be taken care. If any other devastating conditions the patient is addressing on has to be taken care, and your regular renal function monitoring should be done when you are supporting these drugs. The worst or disadvantage part of this drugs are your renal toxicity and the cost of the drug. 50 gram vial costs somewhere around 3,500 to 4,000 rupees and depends upon the company which has been marketed. Some companies charge a bit more than this. I think it's not been available right now over the counter, like a war room setup now. The government has been purchasing these drugs due to the scarcity of the drugs, and the government as a central store has been going to supply it right now. So we have to, and even though it is not our part to manage this, as dentists, we can't manage it as medically or surgically. It is our basic protocol. Means we have to know something theoretically regarding this particular point. Best choice and what should be. And for that, I'm just addressing this for you. There's a clear-cut chart by the global standards stated by the SAARC countries, South Asian countries. They are gathered it up, and this has been in the Lancet, and it's a global standard article which is stated, and this has been followed till now. It's published in the 2019 November, and you can just take them so that this gives you an exact idea regarding the dosage of the drug, how it's being used. There is one more drug called as the Lysosomal Amphotericin B, which has got the tendency to cross the blood-brain barrier, and it's a lipid-based amphotericin B, and this has got comparatively much more lesser renal toxicity than compared to your regular amphotericin B regular. And also this can be used as a passive targeting in places where you have in your surgical site, which I'll discuss when I'm into that slide as such. Surgical management. Aggressive early debridement of the necrotic tissue till healthy bone is reached is a cornerstone for the surgical counterpart or the surgical treatment counterpart. Because once you see that, as I told you, if you find that there is a mobility of your central, your canine or the premolar region, if you extract it, if you find that there is necrotic tissue, you shouldn't wait for, then you have to plan your surgery in such a way that you have to take up the case in order to open up the flap, see the amount of necrotic bone over there with your history, pathology reports or whatever is available with your radiographs and things. You have to make sure that you are going to open it up and do a debridement to the extent of what. If you are able to remove in the initial stages itself, if you're able to remove the necrotic and the debrided tissue over there, then you can arrest the disease over there with your medical counterpart. You prevent further progression of the disease upwards into the orbital arm. Thereby, you are going to salvage your orbit and save the life of the patient. But ultimately, you end up with a minimal morbidity by losing the alveolus, losing a couple of teeth over, which you can always convince the patient, which is better, losing the life, losing the vision, or you losing a part of your teeth and your alveolus, where you can always replace it with a denture or an obturator, which is again a harming thing, but still, at least you will be able to save the life of the patient. And once you start nibbling or debriding the tissue, necrotic tissue, which is seen over there, you do it till a level you reach the healthy bone or your bleeding spots, and then you stop it over there. And to certain areas where you feel that you haven't extended or even after removing this bone, next day you can end up with the same being spread back off. You might have to do a couple of more surgeries related to. You can't address with a single surgery and get away with anything, or unless and until you see that the signs and symptoms are slowly coming down with your ENT colleagues doing an endoscopic examination to see whether there's any more necrotic bone remaining, or is it spreading more towards the cranial base or towards the orbit, or is there any more clinical parameters such as your orbital involvement, also ophthalmoplegia, or anything related to orbit as such. Then there's again a liposomal amphotericin, as I told you, liposomal amphotericin B serves as a passive targeting. Localization of the drug will be there by packing it or as well as IV. And the safety of this drug is infusion reactions are minimal with this particular drugs, and but the disadvantage part is it is much expensive or double expensive. It's 2 times the cost of your amphotericin, which you get it. Then your total on a surgical counterpart, either you might end up with a total, partial, subtotal, or infrastructural maxillectomy, depending upon your involvement of how much it has extended or involved to the base of system, means or to your midface region. And then reconstruction part is the later part of our thing, which we as dentists, when the patient survives and comes back to you, you can always address the patient later with an obturator supported with a denture and all these things. These are some of the, to just come for the sake of completion, I just put in some photographs where you address the patient with the surgical procedures like surgeries, like if it is extending to the part of your orbit, you go in for a Weber-Ferguson incision with the lateral craniotomy and all these things. You extend it to the level so that you can, even with the help of your ophthalmic surgeons and your AND colleagues, if needed, you can go for an orbital excenteration. Now, if it is restricting to the maxilla alone, and if there is no involvement to the mucosa as such, it is easy in the early stages. If you have involvement to the alveolus or your teeth are mobile alone, and if it hasn't gone through, a simple procedures like opening of the flap, removing the alveolar part of it, which is necrotic, debriding it completely up, and if your flaps are healthy enough, you can always suture it back and close a communication. You might, if there is no ulcers or fistulas or communications as such, and if your soft tissue is that healthy, you can always end up without a communication from the oral cavity to the sinus or to the portion where you have debrided or surgically taken off. That is again depends upon the initial or the stage of the disease where you diagnose and where you treat it. And that is why we always address that initially, if you get it in a very early stage, you can always address it promptly. Of course, once your surgery is over, then our part as dentists, we can always, everybody can, we might be facing a lot of patients hereafter with this particular scenario. So come to you after resections, you need to have a reconstruction, means an obturators supporting in order to prevent your food from regurgitation or just going up, or even a patient can't even take a tablet as such if you are going to leave it as such. So that our role again comes into play as of later when the patient is completely saved off. Coming to our case, what we've done is, first he had undergone 3 surgeries as of, and initially he went in for an endoscopic debridement with Lysosomal Amphotericin was supplemented with him. Then he developed some nephrotoxic signs and symptoms where he started with the renal problems, where the drug was again changed over, and then he was addressed at the second time as it progressed, moved further with a subtotal left maxillectomy. Still kept on waiting to see each and every day. ENT kept on addressing endoscopic examination to see how is there a bleeding area, is there a mucosal or inflamed reddish area over there, is there signs of healing as of happening over there, and then still it was still spreading over. Ultimately, a left temporal mini craniotomy was being done, and then it's of 7 months follow-up and a reconstruction with an obturator was given, which is now a wheel fitting which has to be changed. This was a sinus endoscopic debridement which has been done. You can see that first from the ostium is coming over. The necrotic bone over there is being removed with the endoscopic procedure. The non-vital bone are being removed, and that's the median wall of the maxilla. And the supposed scenario, the post-CT, after once he is completely cured of the disease and is totally normal, a CT which shows that infratemporal craniotomy, the maxillectomy, and the alveolus, but ultimately the intraorbital floor, the room, everything is saved and his orbit is preserved and he's got a good vision, as nothing has affected his vision. So a timely management and a correct decision have saved my patient, and I advise all of you to do the same, so that at least the patient, when I called him for a photograph recently, he was so grateful and he was thanking me in such a way to say that, regarding the correct diagnosis and the correct counterpart of what has been done. I especially thank Dr. Sherry, Dr. Leather for their appropriate attention and care and their support for making this patient come back for a second life. Otherwise, we would have lost the patient, and that too, when these literatures were there, but not so commonly being addressed, or it was during this first wave of COVID. One of the most recent advances, what has been come out recently for the just 4 days to 5 days, 4 days back, 5 days back, is that the Linguistic Institute spin-off started with the company Vitalix Bioscience, founded by the researcher Dr. Ashraf Ibrahim, is producing an antibody that stems the spread of mucomycosis. That is something great, and if it turns out to be good. They have discovered the molecules that allow the fungus to invade the human cells, and the antibody that are producing target these molecules to inhibit the growth of the fungus as such. And so that is something, and researchers will keep on moving something, because they have to ultimately save the humanity from this disaster. And the need of the hour is our addressing on the patient on timely and getting a correct diagnosis and a correct follow-up and correct management with a clear-cut diagnosis. A bit about white fungus, which I just thought I'll put in, is nothing but the Candida, which we all know, which we are all daily, nothing to be much aware of, means as the black fungus, it is not, it's a controversy, just hype in the media and nothing else to be taken care. It is only the Candida which we routinely see, and that's nothing to do with this. This is what people will, it is not more deadly or anything related to what we face right now. And to conclude with, predisposing situations of mucomycosis would always be taken into account in post-COVID patients. While healthy humans are resistant to such an infection, immunocompromised patients are generally more vulnerable. At the same time, as I told you, patients who are not known diabetic also are getting this problem. So we'll have to look into it. The key to success therapy includes suspicion of the diagnosis with early recognition of the signs and symptoms, which is our part. Correction of the underlying medical disorders and aggressive medical and surgical intervention at the appropriate time is the gold standard of. If you do it right, then our patient is saved. An aggressive surgical approach enhances survival rate, and creating a great awareness among the dentists as well as the public can help them raise the red flag immediately and put it, at least we cannot control, but we can at least prevent or get a control or at least save the life of the patient with reducing the disability of the patient to a much more extent. Shocked to see so many photographs of patients who are getting operated in Gujarat, Maharashtra, and all these places with severe and extensive spread of mucomicosis. The whole of recently, most of us would have seen photographs with the whole of the face getting surgically removed off with reconstruction. Not even the face is totally distorted. Even you reconstruct with a flap from any part of the body in order to have a cover up for your face, and that is the scenario. And we have to wait and watch. And our role, we have a major part to play in as being a dentist, being in this noble profession and being a part of this dental profession. We have to. With this, I thank the organizing secretary, the IDA office bearers, President Dr. Joseph CC, Dr. Deepu, Dr. Faisal, and the other office bearers of IDA Kerala State, as well as the team who had worked with me when I shared the slides with them in order to add on or to do modifications regarding to Dr. Vagismani, Dr. Ravindra Nair, and Dr. Jayanthi, who had supported, and the people behind who had supported me to give me this enough material in order to make up this presentation and present it before you. Thank you, one and all.
Friends, can I just make a little comment about it?
Yes, sir.
You have been saying about the white fungus. And today I have been reading in the internet, of course, from a reliable site, that white fungus is probably more dangerous than the black fungus. Well, I'm not very sure about it. White fungus is not candidiasis. Of course, it has got a white patch on the tongue and the cheek. That's right. But it is basically aspergillus. So aspergillus, it affects basically the lungs. So what happens is that the symptoms are almost like COVID. That is the problem with the white fungus. And again, one of the symptoms that we dental surgeons may be able to look into is that the white coating over the tongue in aspergillus as well. So that is what I have just read in the, I have not seen all these things. I will tell you, this is just the information that I have received from an internet reliable site. There is a difference. What is the difference between black fungus and white fungus? There they say specifically that in the white fungus, cough and black spots in the lungs when you take an X-ray. These are the things that is fever, all these things which are almost similar to the COVID. So probably the diagnosis will be a little delayed. When there is a cough and then a lesion there you see in the lungs, probably they will start giving steroids. That can again aggravate it. That could be one of the reasons why the white fungus will become a little more dangerous. Then what you have to take back home from this lecture is that it is a teamwork. Most of the cases of the black fungus or the white fungus, whatever it is a sinus maxilla, teeth, are the ones which is going to be affected more. And if that is the case, numbness of the face, swelling, abscess, all these things are related to the dental surgeon. So they are coming to us. Probably we are going to be the first person to see the patient, and we are going to be the one which is going to diagnose it. That's a very, very important factor. He has mentioned it very well clearly. So our role is actually very important. And again, when it comes to debridement and excision, the role of the maxillofacial surgeon is very, very important. And when the patient comes like this, maybe we may have to admit the patient, that the patient may be under our care. So the responsibility is with us. So it is important that we should know the entire management also. Because when there is a particular problem, immediately the doctor who has admitted will be recalled in, not the consultant. And the consultant will not be having that much of responsibility as the person who has admitted. So if we are admit the patients, we should know about the treatment as well. So thank you, Joseph, for your extensive lecture, which has given us an extensive or insight into the black fungus and its management. Thank you very much.
We have a lot of questions coming up. I'll just read out the questions. Dr. Jayanthi, can you give insights about the white fungus and the black fungus in the oral pathology point of view? And how can you differentiate this fungus from other fungal infections?
From clinical point of view, both mucormycosis and aspergillosis, both of these are saprophytes. You see them in the soil and the surrounding environment, and they are opportunistic infections. What is very important here is the normal oral nasal mucosa and oropharynx in a healthy immunocompetent individual, some amount of these fungi have been cultured. So it doesn't mean the presence of these fungi in small amounts in the mucosa is anything that we need to be alarmed of. What is more important is the tissue invasion. That is, these fungi have to enter into the tissue, and that's when they cause the destruction. And that is possible in most of the cases because of immunosuppression. And that's what is happening now. I have seen around 4 or 5 cases of mucormycosis patients, which I have diagnosed in our lab. And all these patients were immunocompromised, and most of them, all these patients were having diabetic ketoacidosis and uncontrolled diabetes mellitus. However, there are a minority of patients, like around 5 to 15%, who are immunocompetent and still they develop this disease. So how does that happen is the epithelial barrier is lost. If the tissue invasion has to happen, the epithelium of the nasal or oral mucosa itself acts as a protective barrier against pathogens. Whenever there is a chronic sinusitis or any chronic insult or local trauma or surgical procedure in that area, that epithelial barrier is lost, and that is also an important pathogenesis, how this fungi can cause tissue invasion. So to summarize, predominantly, the predisposing factors are immunocompromised conditions for both these fungi. However, in a minor percentage, you also get it in immunocompetent patients because of chronic insult to the epithelium or chronic trauma. Now, the clinical features are almost similar because both of these spores are inhaled and they enter the sinus, and from there they invade the bone and enter into the pulmonary aspect as well as into the oral cavity. And both of these organisms have a tendency to invade the blood vessels and cause necrotic tissue. However, the diagnostic aspect is slightly different. And why do you need to differentiate these two fungi? If both are fungal infection, the mechanism is same. Why is that important that you need to differentiate whether it is aspergillosis or mucormycosis is the next question from the clinician point of view. Thing is, they don't respond to the same type of antifungal agents. Dr. Edward has shown us the Lancet article, which is the European Confederation on Medical Mycology. They have given guidelines for treatment of mucormycosis. Any type of species, we have around 30 to 35 species causing infection in human, any type of species, they respond universally to Amphotericin B, and posaconazole and isavuconazole. But that's not the case with all the cases of aspergillosis. They might not respond to the same type of treatment. So that is why it is important to us, and the prognosis and the progression of the disease also might be different for these two cases. So it becomes really important that you differentiate between the two, though you have some clinical overlap between the clinical features, and that can be done mainly through histopathological examination. The morphology of the fungi is different under the microscope. So using special stains like periodic acid Schiff or silver stains like methenamine silver, using the morphology, it is easy for us to differentiate between these two fungi. Cultures may not be always positive, and they specifically mention, literature mentions that anything with the culture negative, you can never rule out mucormycosis. You always have to take into consideration the clinical features, the CT scan features, and the histopathology, everything together, and then you come to a diagnosis.
Thank you, doctor. There was one more question regarding the prophylaxis for mucormycosis. Is there any prophylaxis for mucormycosis?
Prophylaxis, you cannot advocate the use of antifungal agents to a patient who has not been histopathologically confirmed with a proper diagnosis, because you cannot justify the usage of antifungal in anyone. Prophylaxis, I think you can just prevent by maintaining the oral hygiene, especially in immunocompetent patients. If their oral hygiene is poor, and if there is an open wound, the wound itself acts as needed for the fungi to grow. It may be an extraction wound or any kind of physical trauma to the oral cavity. So maintaining the oral hygiene to some extent may help, but I don't think so any drugs will help in prophylaxis and preventing these fungal infections.
Thank you, doctor. I'll get back to you after some time. Dr. Ravindra Nair, is there any protocol for treatment of, written protocol for the treatment of COVID patients, I mean, post-COVID patients? When can we do surgical treatment or endodontic treatment for COVID patients?
I mean, as such for the dental surgeons, isn't it?
Yeah, that's.
Yeah. Basically, there is no protocol as such. I have discussed it with the people who are treating the COVID patients. What they have said is that if the patient is otherwise healthy, you can go and do that necessary treatment. There is no protocol as such which prevents us from doing any dental treatment. Basically, regarding especially now the fear is regarding the mucomycosis. The one thing you have to understand is that it is rhino-orbito-cerebral mucormycosis, which is more common to the face. It is not rhino-palatal or rhino-maxillary. So basically, you have to understand is the mucor always enter the body through the nose. These are inhaled, not eaten, or it is very rarely, and there is no record that it is passed through the oral cavity or the oral mucosa into the body. So as such, if the patient's general condition is good, then that will be the clinician will have to decide whether you will go for the necessary procedure or not. You cannot say that you have to wait for a certain period of time before you do a particular treatment. The one thing you have to note is that the one care you have to take is that in a patient who has undergone COVID and who has been treated with steroids, you have to make sure that the patient on a steroid patient will be immunosuppressed. And on to that, if the patient is having COVID-19, which also suppresses the immune system, and along with that, if the patient is having diabetes mellitus, again, which suppresses the immune system, then you have to be very careful before doing any procedure. So simply having a COVID-19 without any complications, the patient had a headache or anything, didn't take any steroid or anything, you don't have, that is the 99% of the patient belong to that category. Only very few patients actually requires hospitalization and all that. So do not push all the COVID patients away from the possible dental treatment, which they have every right to get.
Is there any time frame for doing dental treatment? This question
that
was asked
is what I said. there is no time frame given by anybody. So first you have to understand that this COVID-19 is a new disease. All the protocols are evolving. The initial protocol given in March 2020 is no more relevant because people have changed it. So similarly, but the present issue is the mucormycosis. Mucormycosis is an old disease. It is not a new disease. The COVID-19 is a new disease. COVID-19 and mucormycosis together is what is the issue over here, isn't it? As far as the dental treatment is concerned, a person who had undergone COVID-19 without any possible other complications as such, who had just a headache, a small fever, and got cured within a week or something, I think he can go undergo extraction, and we have done extractions. And without any other normal dental procedures, I think they can very well go ahead.
There are a lot of questions regarding the mask, the quality of mask and wetness of mask. Is there any literature which shows that wetness or other damp mask can cause mucomycosis?
No. But one thing you have to understand is that from the aseptic point of view, when we wear the mask in the operation theater and all, ideally we are supposed to change it between 3 to 4 hours, because while you are breathing out, that inner part of the mask gets wet. That wet region is actually becomes very good for a possible fungal or a bacterial growth, which is incidentally bad for the person wearing it. So naturally, if you are wearing a mask which is wet, and nowadays, as you can see, most of our people wear the mask in their chin, and they happen to pass through the area, they go to the and do the work, the main work or whatever the work on the soil, and ultimately they push it back. So that time, suppose the spore is there, it gets a favorable environment where possibly it can grow. And if the other factors are there, like the immune system compromise and all, then this particular fungus might enter into the cells and probably may lead to this issue. What you have to understand is that as of today, I think from what I saw from the net is that almost 8,000 or 9,000 cases of mucormycosis have been reported. But you have to take into consideration that more than 2.5 crores people in India are affected. So even now, even though mucormycosis is an endemic, but nothing compared to the COVID-19. What I understand from the increase in the mucormycosis is that, as I mentioned earlier, this COVID-19 is a new disease. And in the initial stages, if you remember the newspaper and all in 2020 and all, everybody was hearing about cytokine storm. So there is something called a cytokine storm which kills the patient. That is what everybody was thinking about. So now the question came, how are you going to address this cytokine storm? Then somehow initially that HCW was there, other drugs were there, but suddenly they came into, they found that simply giving steroid is going to cure it. So what happened was the steroid were started by the intensivist, and later there were even people giving what is called as COVID kit to patients who are in their home care, who were sitting at home. But to prevent a possible respiratory issue from developing, why can't you have a steroid? And the steroid, as you know, is available over the counter in India. So people started taking steroid. That may be a reason which probably has led to a surge of patients in India. That is my take.
I fully agree with what Ravindra and Dr. Ravindra said. And again, one more point I just wanted to tell is that any area which is wet is not considered to be sterile.
Yes.
The wet area is not sterile. So that is also very important. That is one of the reasons why when there is an injury, we always say that, you know, it has to be kept dry, not wet.
Yeah. Dr. Joseph Edward, there was a question regarding the extraction of the tooth from the affected area, that is the maxillary tooth extraction. Is it going to exacerbate the condition, or is it going to help the condition? I mean, rejuvenation.
See, extraction has to be planned. Means, are you asking about a normal dentist doing an extraction, or are you going to address it to
Extraction
by a normal dentist? Is that
Extraction after COVID recovered patient?
Yeah.
That is what is more concerned, because we are taking the history now.
In one particular session, I just mentioned that if at all, there's no clear-cut guidelines like what Dr. Ravi has told to refrain from extraction or anything as such. But if you can, in a COVID patient, do means prevent or refrain from a orthodontic extraction or something which is not an urge or a must, it is better. So at least to be a minimum of 3 months or something, so that you know exactly what the scenario of the patient is. Is he diabetic? Is he going for any sort of related problems as such? But in other scenarios, certain cases, it becomes essential that you have an infected root stem or a caries tooth leading to an abscess where there is more, other than your mucomycosis or anything as such, there is a need for an extraction, because you can't keep on waiting for an extraction root stem or an infected tooth to be there for 2 to 3 months or prolong it. So I think a must for an extraction as indicated is a must there. But in a scenario where you find that there's no related signs and symptoms as such, and the patient comes to you with a mobile tooth, especially the central lateral, or as I stressed on, the canine and the premolar region, which is first affected, which result in severe bone necrosis with mobility, I think that particular point has to be looked into. Whether if the dentist is going to do that, he might end up in trouble because he is not able to address the situation at that particular point of time. How can he send that patient back to a maxillofacial or somebody who's going to do a surgery to say that I didn't encounter bleeding? Means the other person has to do. See, from a surgical point of view, I just addressed that if we are on a diagnostic measure with regarding a particular tooth being mobile without any of the symptoms as such, and with the clinical findings of what I have just mentioned, a pain, radiating pain over that side of the face and all these things. And then after that, the surgeon can easily go in for an extraction, getting the consent of the patient, properly explaining, saying that you have not done a wrong extraction. It might, sometimes if you do the extraction and you find that there is proper bleeding from the oral cavity, but that could be a diagnostic, and that shouldn't turn up as a later stage for a litigation or a problem stating that means we have done a wrong extraction or we haven't done a proper right treatment. It is regarding that addressing the patient properly, getting a proper consent and making sure that you do an extraction, so that, because this was being discussed early in the morning and that has been discussed by one of the leading surgeons who are doing a lot of surgery, Nihal Patel, who's doing a lot of surgery. Dr. Nihal Patel is being a lot of, and he has addressed saying that it would be diagnostic, a good measure to go ahead with this particular tooth extraction to find out whether what the condition, the underlying condition is. Is there a bleeding from the socket? Of course, if you have a fresh bleeding from that, your bone is vital. Or even what he said is when the endoscopy, the ENT surgeon does an endoscopy, he even makes an incision on the anterior maxilla, puts in a blade, reflect the flap and see whether there's bleeding, how the bone is there. Because the CT, which has taken 2 days, would have changed the total scenario. So it can be addressed in different aspects as such, and it is the choice again for the surgeon.
Yeah, if you don't mind, may I ask the point across? This basically we're trying to discuss what kind of light can be thrown with regard to the general dental practitioner's point of view. So if I may ask, would you suggest a blood picture be done before doing an extraction in a post-COVID patient? Would you suggest that? 1. 2, invariably not all cases will be mucormycosis or a fungal infection. So then the scope of reference for every extraction does not arise. And as the COVID alters the blood parameters to a certain extent, what would be your take on that to any of the panelists?
I feel that, nowadays, I think that there is nothing, especially we are definitely going to take the history. And if the patient is not giving you the history, there is nothing wrong doing a
With specific, may I tell something, sir?
Yeah, please go ahead.
Specifically, what Deepu asked was any blood picture is necessary prior to a dental extraction. What you have to understand is if the patient has had COVID-19, naturally there is going to be neutropenia and leukopenia. Even if the patient has recovered from that, there is every possibility of either leukopenia and especially neutropenia. If that is the case, that is a warning sign that you shouldn't take up the case unless it is corrected. When there is neutropenia, that the patient general immune system is down, in which case it will not be safe for you to take up the case for the time being. You can always do an emergency measure, pain relieving measures, probably remove the pulp if it is a pulp which is causing the pain. You can do that, but preferably don't do a surgical procedure unless you correct the root problem of the neutropenia. And what was the second part you said?
Basically, I think you've answered the parameters, blood parameters being changed.
No, one more thing you said.
Yeah.
Or regarding the general dentist, how actually I have a take in that. Basically, because what you have to understand is the patient will come to you with a complaint with regard to the teeth and other areas. Naturally, if you want to have a complaint like pain, tenderness, or inflammation, you need to have a certain disease in the dental or the paradental region. If you suddenly find to have some pains which is not clear, first you have to generally understand that the mucormycosis of the past was different. Now the picture and the clinical picture, what the people are seeing is different. So if the patient comes to you and say that there is a particular pain in the particular tooth, and when you examine, you find that there is no dental reason for that particular pain. You find that there is no possible dental reason for that particular pain. I think it will be always advisable if you can refer the patient to an ENT surgeon, because in mucormycosis, one of the initial changes seen is that the middle turbinate region, the mucosa becomes pale, which if an ENT surgeon examines, probably he will be able to see that instead of the normal mucosa, which is pink, it is pale. This may be a pointer that probably this patient, a post-COVID patient, probably might develop this. So if a case like that comes, whether you cannot find any reason for that particular complaint from the dental point of view, I think nowadays, because of the number of increasing, I think for every dentist to err on the side of caution is better.
Sir, I would like to add one more point. A routine blood counts, when you look for the blood investigation, looking for a routine blood counts like WBC and other counts, I think it is also important that you look for the diabetic status, even if the patient is not giving a history of diabetes. Because unfortunately, in countries like ours, where we don't go for a regular routine checkup, like how foreign countries, people in developed countries do, there are many cases of mucormycosis in India where, because of mucormycosis, the underlying diabetes was unmasked. So that was the condition in many situations. So maybe the patient even is not aware that he or she is diabetic. And especially if they had a history of COVID-19, the COVID-19 disease itself has modified their metabolic state, and a previously undiagnosed diabetic patient may now become a diabetic patient, or a patient who is diabetic may become an uncontrolled diabetic patient because of this immunosuppressive condition. I think so. If you're planning for a surgical procedure or an extraction, in addition to doing a routine blood counts, it is also important and necessary to do their check their diabetic status.
Very correct. Can I add something more? Basically, what you have to understand, if the patient had a COVID-19, the COVID virus has a susceptibility to beta cells of the islets of Langerhans. So there is every possibility that a post-COVID patient, even though not diabetic before, could turn out to be diabetic. So it is a very valid point from Madam that you have to check the glycemic status of the patient along with the other thing, basically considering that COVID disease as such is possibly a diabetogenic disease also.
One more can I add on? Oh, I don't know exactly whether we can put this into the serological examination, such as your galactomannan 1 and 3 and your beta D glucan test. When don't know how much it is going to cost. That is again a factor. This is one of the serological tests where you have a differential diagnosis for fungal infection. But I don't know whether how far to how extent can be practically put in possibility to check all these patients for this, and the cost going to come up to for a routine procedure, for a surgical procedures to look into. That is only a diagnostic test for the fungal growth as such, or fungal infections as such. I don't know how far is it, or how costly is it? You have any idea regarding the same?
When we have very classic or clinical manifestations with proper CT findings, and if we are able to demonstrate the fungi histopathologically, I don't think so there is a need for this serological diagnosis. These markers have been primarily used now. They are under research now in cases which are culture negative and where the microbiological tests, they are not able to demonstrate the fungi. Very few percentage of cases, you have classic signs and symptoms of mucormycosis, and CT scan and MRI shows extensive involvement of the rhino-orbitocerebral area, but still, unfortunately, we are not able to demonstrate the fungi histopathologically. So, and as an alternative method, people are working on these kind of serological markers. For routine diagnostic purpose, I think it has very less value because, as you said, it's still evolving. So the availability of the institutions where it can be done and the cost involved in that, I think we can avoid that for a routine practice.
One more thing, can Dr. Jayanthi just stress on that KOH staining, the past staining, so that we can get an early diagnosis regarding the FNACs?
Yes, this potassium hydroxide 10 to 20% has been very commonly used for early detection of the fungi, even in swabs, smears, and in histopathology. But unfortunately, you don't get the contrast there. So we have to keep in mind that we are identifying this fungi based on their morphology. So when we don't have a contrast, it becomes little tough, and you need a really good practice and experience to identify these fungi. So they have been using fluorochrome brighteners like chalcofluor white that will help us identify it easily. All this will take only maybe 1 or 2 hours for the diagnosis. And I think in the initial cases, if you want to go for surgical debridement, before that, we can go for this KOH staining or even periodic acid shift staining on the swab. And then the surgical treatment can be planned accordingly. And once the surgery has been done, the final confirmation can be made on tissue histopathology.
Okay. Dr. Joseph Edward, one question for you, doctor. How long it will take for the radiographic changes to take place from the initial changes in mucomycosis?
See, mucomycosis is fast spreading, so it's an aggressive thing. I think I can't be specific to the number of days to how much. Initially, when the patient complains to you with a pain or with any sort of clinical findings as of now are not there, but still the patient has got a pain. There's no intraoral findings, extraoral findings, no orbital findings as such. But when the patient complains of a pain, as I told you, I had a patient in the ICU, post-COVID patient on ICU having pneumonia, diagnosed the patient, saw the patient, went in through, had a thorough oral examination, took an X-ray to find out there was nothing related to the tooth. We suspect that, or the intensivist and well as the ENT had a team for suspected that this could be the start of a mucomycosis. That is why he was having. But on that, at least we had some changes, or the sinus was getting filled up with, you have a polypoid like type of growth on the sinus, but there were no relevant changes to the bony structure over there. What happens here is, it takes time for the fungus to breach the lining of the the sinus cavity to enter into the bony wall. And when it reaches the bone, it has got if it is a thin papery bone also, has got a marrow cancellous inner part in between. It starts off with that. Then it blocks your Haversian system and all these things. By the time, if you're going to take with the CT, how far you're going to get the exact scenario of it. But if you wait for at least means if the disease is keeping on progressing as such, then in a short couple of days, you might get because this is like fast spreading, it's mouth eaten, it takes up your bone like anything. So, and one more thing to be added when the first question in between, this is a question which has been asked earlier. Even in today's discussion in maxillofacial unit, what we found that was there's one doctor, a senior infection control doctor from Apollo Hospital has stated there's no preventive or means empirical treatment shouldn't be started or in the sense, not an empirical, sorry, a prophylactic treatment for mucomycosis should never be done. And that doesn't serve any purpose. It doesn't have any role over there. At the same time, the drug itself is nephrotoxic and the cause of the drug. No, it is not that alone. We are in urge of the drug right now and the country is facing great difficulty in having the drug. So at the time, the drug should never be misused and it doesn't have serve any purpose of having a prophylactic or people going to start with, and it will not be available over the counter for anybody else right hereafter.
Dr. Jayanthi, one question. Will the mucormycosis affect the lower jaw, the mandible? Is there any chance for mucormycosis to affect the lower jaw?
It can affect, cannot say it can never affect. That's what I already mentioned. There are a few percentage of cases which have been shown to occur following trauma or surgery, and in patients with severe burns, and especially if it's a road traffic accident and patient had a trauma and there is contamination of the soil, and if the same patient is immunocompromised in some way, like a diabetic patient or something, and that can help in the tissue invasion of the mucor, and that can produce lesions in the lower jaw, though it is not very common as you see in the upper jaw, because the spores are inhaled primarily, as Dr. Ravi told, the spores are inhaled primarily through the nose. They enter the sinus, and by breaching the bone, mucosa of the sinus, they invade into the oral cavity and cause destruction of the bone. That's why predominantly you see clinical features and involvement of the maxillary bone. But however, it can occur in the mandibular bone if it is associated with a trauma or a surgery or any other kind of route of infection. It has been reported in the mandible, though it is not as common as in the maxilla.
Dr. Shibu,
Yes.
Shibu,
Yeah.
you want to add something to this?
Can I add one more thing regarding?
Sure.
See, there was also a discussion on clinical findings. If you find that there is a bit amount of sequestral bone extruding out of your upper jaw or something related as such, the necrotic been thrown out, that shows that there is a bit of immunity or your body is fighting against it. And those cases which the surgeons have operated has found more having better results, because it has not been staying inside with the soft tissue coverage. It has been rejected out and the debridement part becomes more easy. And when you are going to debride it or remove the necrotic bone, you can find fresh bleeding on the available bone back over there. And that is one of the recent findings which certain people have found in affected mucomycosis affected patient, where there is denuded bone or sequestral bone similar to osteomyelitis, which comes out, which projects out, and without a soft tissue covering. And that was to be added on, which I have just left it out. I have just remembered that and just said it back.
Dr. Shibu.
Yeah. This was a very wonderful CD program, and in this COVID time, more and more challenges are creeping in, and the latest being the mucomycosis. Today also I come across a WhatsApp message by Dr. Reddy from Assistant Dental College itself, that they have diagnosed this case and they have treated with medication, maxillectomy and FSS, this functional endoscopic sinus surgery. So this mucomycosis is rampant nowadays, and this CD definitely throws light to the various aspects of mucomycosis. I appreciate Dr. Joseph Edward for the wonderful presentation. It was so elaborate, comprehensive, and informative. Thank you, Dr. Joseph Edward, for that wonderful presentation. And thanks to the senior oral surgeons, Dr. Vagismani and Dr. Ravindra Nair, for their informative inputs. And also Dr. Jayanthi for enlightening for that pathological aspects of this disease. Big kudos to the CDA wing once again for these wonderful CDA programs in these COVID times. Thank you all. Thank you.
What is our participant strength? Okay. Any idea?
Dr. Ravi,
at one point.
Yeah. Dr. Ravindra Nair, one question to you, sir.
Current way.
Sir, the question to you is the antibiotic abuse or overuse a cause for mucomycosis nowadays?
Antibiotic overuse, I don't think so. Because I think it is more of a steroid overuse is the issue. Antibiotic overuse, unless the patient is immunologically suppressed, mucormycosis as such doesn't occur. You get oral thrush, candidiasis and all you get, but I don't remember ever seeing or hearing about an aspergillosis or a mucormycosis such conditions where mucormycosis, especially when the mortality is 70 to 80%, such a disease occurring due to antibiotic overuse. Especially now in the last 1 year, actually it is the steroid overuse is the issue instead of the antibiotic, I think.
Next question is to...
It can be a contributing factor also.
Could be, sir.
Next question is to Dr. Deepu. Can Dental Association provide patient information regarding mucomycosis?
That's a tricky thing because we'll definitely look into it.
No, actually,
well thought out and well addressed. We'll have to take the consideration of all the specialties when we
Deepu,
definitely look.
Like Dr. Joseph said in his presentation, he can design posters regarding this.
True.
Deepu,
Yes.
1 second. Actually, in the morning session only when we were discussing, actually, this is something actually our association can, I think, take up. That in the clinics and all, we have put posters regarding the COVID-19 and all in our clinics and all those places. Yeah. Similarly, you can put posters stating that there is a disease called mucormycosis, which can affect any people, and especially a person who has recovered from the COVID-19. So it is always better to use a mask which is what you call dry, and never to reuse it for again and again and again. And if at all you develop any pain or fever or any pain on the facial region, swelling, these things is immediately should be brought into the notice of a doctor. I think such a small item can be good.
That is what I was coming to say.
Our CDA chairman is here. Sushant is here. He can be interested.
Exactly what is coming. It's a multidisciplinary approach that we need to take, and we'll take inputs from all the concerned departments, and we'll definitely create a poster. That's definitely on the line. It will take a couple of days, and we should be out with it.
1 minute. Can I add on something? If the IDA authorities can look into put in a word to the government regarding government is stressed on all this. We are aware of that. Everybody has to wear a mask and all these things. But wearing a mask and the right position, right. But nobody has ever been advised to how long a mask should be worn or how far it has to be changed and all these things. Not considering the mucomycosis scenario alone. Otherwise, also like a humid mask or a dampened mask, which were worn twice or 2 or 3 days or more, or even which has been washed and not dried properly. It can cause so many hazards to the patient. Breathing same, providing a harbor for your bacteria and fungi to work on it. So taking into consideration mucomycosis as well as preventing the patient from having other chest infections or related aspects, why don't we put in a word with the government or give a stating that to have a public information regarding the same, that at least they wash their mask, they have it 2 or 3 sets of masks and wash their mask. If it is cloth mask, to wash it regularly, dry it properly on sunlight and then wear it back, or they have to change it in a particular period of time, or at least to the maximum of a day or half a day, or keep it one for a spare. So if that can be brought, that will be a good public information being provided to the authorities or to the government as such.
Actually, there are protocols that have been released by the DHS, and the Chief Minister in his daily briefing has mentioned about the usage of masks and how you should watch. This is something that is not percolated down to the general public instance, but there are advisories which we can also maybe IDA can come out with such things. We'll definitely look into that.
The point I think Joseph mentioned was there are advisories regarding wearing double mask on such things like that, but there are no advisories regarding removing the mask and reusing the mask. That is the point.
Of masks also there are no advisories.
That is what Joseph was
yeah,
saying.
definitely. We'll look into it.
One last question to oral surgeons. When can implants be given after partial maxillectomy? In those cases.
In those cases.
In mucomycosis cases.
Over there. See, you don't have a maxilla, you don't have a pterygoid bone, you don't have anything over there. So when after all the stage is, when can you rehabilitate and how can you rehabilitate is the next question. If you want to go for a pre-collapse or something, only after your total recovery of your present scenario, after your mucomycosis is cured completely, and after months after that, you can go for a pre-collapse or something. Other than that, and if the patient can afford for that, other than that, the obturator is the best. But instead of to put in an implant, you need to have bone. You don't know the extent of involvement, or you can only decide on how far the surgical extent goes of. So where are we going to put in? If you need to put in, then it is only after a couple of months later when you go for a pre-flap or something, or with an arterial anastomosis and all these things, you can put in a flap back with a composite flap with a bone and a soft tissue, and then give implants on it, and only then can it rehabilitate it. And that is going to be the biggest disaster year after, because now you will get away with all these things regarding saving the life of the patient. The next is the challenging part. You don't know, when cancer patients, of course, those who are associated to cancer units know after resection how they find it difficult to keep an obturator, fitting dentures or an obturators. This is going to be widely been spread out if the scenario goes the same. And our dentists, you can't keep on approaching each and every place, or all restaurant. Each and every dentist has got a role to do if the cases keeps on increasing, and that we'll have to rehabilitate for our functional usage in order to swallow as well as to eat a food properly. And then we will think about implants later, somebody who can really afford to after post-surgery. Am I right, Dr. Ravi?
No, you are. But I think first thing you have to remember is that generally after the mucormycosis, you do not lose the bone alone. The more difficult part is the loss of the soft tissue. If you don't have a cover for any of the bones in the upper face, unless you get a cover, unless you have a soft tissue cover, only then you can think of the bone. When you have the bone only, you can possibly think of a implant or any other. Bone means viable bone. Unless it is a viable bone, you cannot think of the implant. Generally, the algorithm for the management of reconstruction of the upper face is not very easy because of the shape and the different types of the bone. So once a mucormycosis patient has survived, then that is going to be a huge process of reconstructing the soft tissue. Whether you have to do it in a single step or a multiple steps, then only you can probably, the last step of which could be probably implantology. Probably places like France and all, they have the whole face has been reconstructed in a single day and all. But as far as we are concerned, we are probably will have to think of 2-stage or 3-stage procedures. That's my take.
And immediately, what I can add on, immediately for reconstruction, what we do is the earlier means even temporalis rotational flap to cover up the defect is not advisable nowadays, because what happens here is, in order to readdress the lesion, or if it is keeping on spreading, immediately we can't go, nobody advises a immediate reconstruction. Even that soft tissue flap or like temporalis or buccal fat or whatever it is, because everybody wants to go back every day, see what is happening, get arrested of this spread of this disease, and then only they are in a position to treat it back. So you can't ever close it up and then leave it as such, because once you close it up, you're not getting lost with the whole of the area. You can't even approach the area to see if it is again progressing, or is there any remnant, or is it involving the skull base or anything as such. And coming to the reconstruction part again, mandible, of course, if you resect a part of the mandible, it is easy. You can even go for a free graft or a free flap or a devascularized flap, bone graft, and all these things, because the shape of the mandible is such a way that you can take an iliac, femur, tibia, whatever it is. But maxilla, as Dr. Ravi told, is a bit complicated. So reconstruction part itself is a challenging thing. Hope Dr. Vagismani will also agree with the same, and he'll be able to narrate more on it.
I think.
Sir might have gone for dinner.
Sir, one question from our working committee member, Dr. Shafi. Why occurrence of mucomycosis is there in our occurrence is high in our country, whereas when it is compared to the international level?
That may be because of the patient themselves will seek late entry to the hospitals and doctors, especially in North India, especially during the COVID prevailing times. Patient may not be aware that this is a very aggressive disease, or it needs immediate medical attention. And that is why maybe what you suggested, to keep a patient information sheet in the clinic, would be helpful to educate the patient that the importance of getting early diagnosis. If you don't go early, then it will spread very rapidly, and then the morbidity and mortality increases.
No, I think I have a different take, in the sense that what we have to think of is the climate of our country. Climate of the country, our country is more warmer and humid, which is more conducive for the growth of fungus. Unlike maybe Finland or those places which are much colder, probably that may be the reason why we have more number of mucormycosis cases. And another point is that which I mentioned earlier, the number of COVID cases is much higher than that which happened in most of the European countries, where we have 2.5 crores of people which are affected, whereas in many other places number was much less. Both could be the reason. No definite answer as such.
One more thing is regarding diabetes. We have somewhere around
diabetic capital
of the population as diabetic in India. So that is again a contributing factor. So compared to the rest of the countries.
Okay. Dr. Jayanthi, one question is there. Elaborate on specimens for culture or KOH or PAS and centers available for the same.
If you're looking for a routine cytological analysis and histopathological analysis, any pathology lab can do it. We don't need specialized equipment for that. Only for culture, we need to be careful, because as I already mentioned, these mucormycosis fungi, they are very fragile. So if you don't handle the culture specimen carefully, you might end up getting false negative culture reports. So you need a trained microbiologist to do it, and you need facilities where fungal cultures are available. Otherwise, the routine histopathology and cytology, I think pretty much all the dental colleges and even the private pathology labs are equipped to do that. And you get a report, probably say around, if it is a smear, you will get it within a few hours. And if it is a tissue histopathology, you might get it in 3 or 4 days.
One point you have to remember is that, as she mentioned, this hyphae is very sensitive, and if it dries out, it dies out very fast. So once you have taken the specimen or the swab, you have to make sure that that will reach the microbiologist as early as possible, probably within a period of 2 hours. And if necessary, I think to prevent bacterial overgrowth over it, you can add chloramphenicol. That is also advised by many of the microbiology textbooks.
Well, it's around 3 hours since we started. I think it's time to call us, to end the program. Before that, I'll ask Dr. Deepu to give us the remarks, or Secretary to give the remarks regarding the program.
Thank you. It was definitely a very wonderful and informative session. Special mention to Dr. Vagismani for taking the pains off and attending this session here and agreeing to be the moderator. And all the panelists, all the speaker, Dr. Edward, and the panelists, both Dr. Ravi and Dr. Jayanthi, did an excellent job, and definitely it will prove beneficial to the community, the dental community and the profession. Then IDA KSP will stay on the pulse of matters, and we will, within a short span, we will bring out posters regarding this. Suggestions and opinions are always welcome. You can please contact us through all the office bearers anytime, and we will try to deliver as far as possible to help our community stay afloat and for the betterment of the public in the days to come. Thank you.
I
Thank you.
I invite Dr. Joseph CC, our president, to give his final remarks.
Okay. It's a elaborate session. It's a wonderful session. It's really in the need of the hour, and it's a real eye-opener for all the members. Idea Kerala State will come up with a suitable poster on anything to publish in the clinics and all. So Idea Kerala State is heartfelt gratitude to all the faculties, especially Vagismani sir, faculty Joseph Edward, Ravindra Nair, and Jayanthi. So kudos to all the members participated. Thank you.
Thank you, everybody. Thank you.
Good night.
Good night.
Good night all.